Hello, it's Mark Kris from Memorial Sloan-Kettering, talking today about the American Society of Clinical Oncology annual meeting in Chicago, completed a few weeks ago. I think it was a great meeting, and it reminded us the importance of meeting colleagues face-to-face, the ability to network, to learn. I have to say, I never had anything approaching the ability to learn and share in person with any online or any kind of Zoom meeting. I mean, being together, I think, makes a huge, huge difference. I'm just so happy we're able to have that meeting. I think that the tone of that meeting was tremendously upbeat. People felt, and particularly in the lung cancer area, that we had many new opportunities for research and also new therapies to offer our patients. I think we were also struck by the difficulties that we face trying to assure access to the new therapies to all the patients that could potentially benefit. We heard stories from our European colleagues, phase 3 trials done, regulatory agents approve the agent for use for that indication, but then a 1 to 2 year process to get payers to agree to make that drug available to patients. We strive so hard to find these new treatments, get them to patients, and then we have so many stumbling blocks to do that. We just need to find a better way. I think I, for one, was overwhelmed by the enormity of the information. It used to be, at least in the lung cancer area, there was sort of one treatment for lung cancer. Now there are so many treatments, so many nuances. Getting the best information to do that is a formidable task. How to do that is still a work in progress. But I think we need to pay attention to how to take what's available, make sure that it gets to the people that can act upon it, and most importantly, gets to the patients. I think I also like to comment on some of the thinking of the oncology community. I have to say that I saw several examples of people focusing on, number one, negative data, that even if in a positive discussion, and I'm particularly thinking about a discussion about neoadjuvant therapy, the questioning was all about the small proportion of patients that were offered neoadjuvant therapy but did not ultimately go to surgery. The medical literature is full of reports how those patients that did not go to surgery were truly inoperable, they were unresectable, or they had undetected metastases. And it's not, the problem wasn't neoadjuvant therapy. The problem was, sadly, a patient had a more advanced state of disease or a condition that would make them inoperable. The other discussion that came up in that neoadjuvant session was about the use of postoperative radiotherapy. There was a clinical trial a few years ago where there was no significant difference in survival based on receiving postoperative therapy or not. And there was some increased toxicity in patients that received therapy postoperatively because of radiation to the heart. What is lost in that is that when you say it was a negative trial, it did not have its 12% improvement in 3-year survival, which was the goal of the trial. Well, the truth is we've never had that degree of improvement with radiation alone postoperatively. And the fact that we didn't reach it doesn't say that it can't be helpful for many people. Also, our radiation therapy techniques and our ability to gauge damage to the heart and the understanding that radiation to the heart is critical in estimating radiation damage to the heart is critical in assessing the toxicity of radiation. We've gotten so much better than that, and treatment plans can take that into account. So, painting with a broad brush, this trial said it doesn't work, really does a disservice to our patients. I think what we really need to do is dive in to the specifics of that patient and say, does this data truly apply to them? The other thing I think I was struck by is as we improve our adjuvant and neoadjuvant therapies, more and more people are suffering failure in the chest, lung and lymph node disease. So clearly, ways to improve upon that, and radiation may be one of them, need to have some attention. And every single randomized trial ever done has showed a clear improvement in control in the chest with postoperative radiotherapy. So ASCO, a great meeting, a lot of good information, good news there. I urge us all to do our homework, look for the new developments that are there. And I think if I could have a summary statement for the meeting is our job has gotten better. We have better treatments to offer, less toxic treatments to offer to our patients. Our patients have more options open to them and a better chance to keep living their lives. But I have to say it's a lot more harder for us. We need to learn more. We need to be able to process new data quickly and apply it. And we need to make many, many more decisions along the way for a patient, not just the first chemo, but the second chemo and the third chemo, when to do consolidative radiation, all these things that we never had to think about a decade ago, we have to think about now. And if we do that, we'll do the best job for our patients.